Microphone is on. All right, folks, we're back for our 1500 presentation of the afternoon. We have Dr. Dunn with us today for pain management.
All right, good afternoon, guys. My name is Garrett Dunn. I'm here today, of course, to talk about pain management. My goal today is kind of try to give a broad 30,000-foot view of pain management and hopefully make it somewhat useful and relevant for you in the EMS setting, but it's kind of a broad topic, also kind of gives some insight and understanding, into the goals with, the definitive treatment once they get to the hospital. And then a little introduction just for interest's sake into the history of pain management, some of the science behind it. Just a little bit about me. I'm from around the Joplin area, Jasper County. I grew up on a farm around the Avila area, east of Carthage, if anyone knows where that is. Went to high school in Carthage, college, medical school in Joplin, and now first-year residency in the ER residency at Freeman Hospital. So I'm lucky I got to stick around. Very blessed. And of course, if you guys have any trouble hearing me or any questions or anything to add, just feel free to stop at any point. I'd be happy to. Just to go over outline of some of the key points I wanted to hit on today. First, just to give a little overview of pain management and why it's such an important and relevant topic to talk about. Go a little bit into how we kind of measure and quantify pain, which they've made several scales that we can try to use, as well as our clinical judgment, and why it's important to quantify pain and how it kind of aids when we're deciding what to give a patient. And I tried to make this as relevant and narrow down as possible. Some of the drugs you might more commonly have on the trucks, fentanyl, morphine, ketamine, that kind of thing, but also a little bit of dive into other things that if you're getting a history from a patient, you'll see, I take Tylenol, I take hydrocodone, and those things can become important. We'll also talk about some of the history of pain management, how it's evolved from very primitive to now the complex, highly effective therapy we have today, and dive some into the science behind why we have pain, how it works, and kind of build a framework to discuss later how each of these medicines can target our pain. Talk some about acute and chronic pain, the differences and implications for how we're going to approach it differently. And then the bulk of today's presentation is going to be over a lot of the different options we have to treat pain, as far as history, how they work, how they're dosed, which is probably the most important part. Cover a few drugs, more common, Tylenol, NSAIDs like aspirin or ibuprofen, opioids like fentanyl, morphine, ketamine, which is its own little special category, and then some different pain medications that aren't necessarily for pain, but we use them to treat pain, like nitroglycerin in a patient having a heart attack. And then after that, talk about some special populations and how that affects how we treat pain, such as the young and old, organ failure, people who are addicted, and how treatment can be affected by each. All right. So kind of an overview. One reason this topic is so important is that some variant of pain does account for, once someone gets to the ED, around 70 to 80% of emergency room visits, and thus a very large percentage, I would imagine, of EMS calls. Even when pain is not the reason for a call, such as someone witnessed a car accident, pain control can become a very crucial part of the interventions given en route to the hospital. It's important to note that pain has different implications depending on presentation. In a patient with an active heart attack, the chest pain they're experiencing is directly indicating the ongoing ischemia or oxygen not getting delivered to the heart that needs emergent treatment. Whereas in something like a migraine, the pain should be treated, but it doesn't necessarily mean there's some kind of active ongoing damage within the body somewhere. I'm sure we've all treated a patient who wants to avoid being given opioids at all costs. Maybe they've heard about fentanyl on the streets, or maybe they had a family member who is addicted. And then we've also all treated a patient who is requesting them by brand name. And this is kind of a way that patients can take an active role. Some cultures would choose to endure more pain. We've had a lot of people that try to keep their medication use to a minimum, often due to some personal cultural belief, and we can take that into account. And we should always strive, when possible, to treat pain at the same time as the underlying condition. It kind of has been shown to improve outcomes and relationships with the EMS and the emergency department when patients feel that their pain is adequately controlled. So, the first step in pain management is recognizing it and having the patient quantify it to try to help us guide treatment. Pain and suffering, they're all really subjective experiences, and self-reporting of pain is what's considered the gold standard upon which to base the treatment. Provider first impression, we all have our gut feeling, our gestalt of looking at the patient, seeing those nonverbal signs, seeing their vitals, their heart rate's fast, they're breathing really fast, facial expressions. Those can not always be 100% correlated with the patient's experience of their pain. So it's important to self-report and kind of use that as one of the things you look at in guiding your pain management. Of course, it's important to reassess the patient periodically for seeing, was my treatment effective? And hopefully by the time you're redosing medications, the patient has already arrived at the hospital. But sometimes you're going to be on those long transports from facility to facility where this might become important. And then they've created multiple scales that are not all 100% the end-all be-all, but they can help us try to quantify pain and something to think about. I'll mention a few here, but the purpose is to kind of help create an objective quantifier on the degree of pain, taking it from subjective to here's a concrete number, and it helps providers kind of select and administer analgesics or pain medicines, or the idea being you have someone with, my pain's a 1 out of 10, okay, let's try some Tylenol, versus, I have a tree impaled in my chest and my pain is a 10 out of 10, that's going to require something different. And then the numbers, on these scales are also good for research purposes, helps them organize data when they're talking about the effectiveness of pain medication. And also, they're a good thing to help communicate with other providers. So calling in a report to the ED, it kind of gives the provider a sense of what they're going to be dealing with when the patient gets here, and also has some implication on the patient's mental status. This is just a, wordy table on different pain scales. This is from a book called Tentinelli's Emergency Medicine. The adjective rating scale on the top there, we see an example of this on this slide, is just a nice little gradient where the patient can mark. They can mark on a segment, or they can mark between them and kind of self-report their pain. It doesn't have to be a visual scale like this. You can just verbalize it. And then there's also one that is visual on the next part, the visual analog scale. That one, not always clinically relevant in an emergency situation, but basically they would have you use a 10 centimeter scale, and the patient, you would mark no pain on one end and maximum pain on the other, and they would mark, and then you would measure from the left end to see how much pain they're in. And for all these pain scales, my goal here is not to get into granularity of memorizing these, but just to get a kind of an idea of these are different ways you might be able to communicate with someone, maybe who's nonverbal, or you can create a scale like this, or different things to think about when reporting pain. The numeric rating, or the verbal quantitative scale, that's at the end of the table here. This is the most commonly used one. It's the one I usually use personally. You give the patient the option to rate their pain on a scale from 0 to 10. Back in the middle of the table, a numeric rating scale is basically the same as this, except now you put a descriptor on it. You say, 0 is no pain, 5 is a moderate amount of pain, and 10 is the worst pain you can imagine in your whole life. And again, these are all good ones for non-speaking patients. They can still hold up fingers and say, this is how much pain I'm in. And then the 5-point global scale is probably the most detailed, fleshed out of this, but it's only from 0 to 4, and then you put those word descriptors that you can see there. And of course, important to remember that self-reporting of pain is still the gold standard. We've covered those key points. So this is a brief history of pain management. So I put some of the points here on the slides, but medicine came from very primitive roots, and up till the 1600s, even the 1800s, we were still in this theory of I need to bloodlet you, or there's 4 humors, bile, yellow bile, black bile, blood, and phlegm, and balancing those is how you treat disease. But we kind of became like a caveman with a torch in the 1600s, European doctors starting to use opium to treat pain in their patients. Started to develop in the 1800s ether and chloroform for surgery. Interesting culturally back then, some surgeons were concerned about the ethics of operating on an unconscious patient, which I found pretty interesting, or that relieving pain would hamper healing. And it is, and also the idea that anesthesia violates God's law. Pain is meant to strengthen your faith, and then that kind of shifted towards the end. No, anesthesia and pain medicines, opioids, those are a divine blessing to help us get through life. Syringe was invented in 1855, and that kind of contributed to overuse of morphine around back then. Towards the end of the 19th century, 1898, Bayer first introduced heroin as a cough remedy, and by 1910, people were crushing the pills to inhale them to get a high off of it. Next year, 1899, they introduced aspirin, which became over-the-counter in 1917, and kind of replaced opioids as a go-to pain medicine. It was around this time doctors began to get a little concerned about addiction, started to look into chronic pain as well. They saw chronic pain as kind of more of a mental illness, and started to put some restrictions on morphine and heroin in the early 1900s. A lot of the advent of different pain medicines was driven by the different wars in history. Civil War, World War I, World War II is when these moments we were developing new different types of opioids in an attempt to try to find one not addictive. And all this being mentioned just to kind of put some context to the world of patients you seem to see today and opioid addiction, which changes your management later on, which we'll talk about. Then we get into more of the modern era, 99 to 16, 630,000 drug overdose deaths, kind of in waves. First wave with prescribed drugs, second wave with heroin, and third with street fentanyl. So we're now in a world with a lot of highly regulated, there's drug monitoring programs out there, and it's kind of the political environment we're living in right now. Is the only reason I mentioned that. Kind of the attitude towards opioids has changed over the past few decades, and it's changed very drastically, where they were a blessing and then demonized, and now we're trying to get back. But the key thing to remember is all this fear of the opioid crisis should never prevent you from appropriately treating a patient's pain. So now getting into kind of the science behind pain. Of course, pain's not an inherently negative thing. We were designed with the ability to feel pain for a reason. We've all seen probably how the inability to feel pain can lead to a severe issue, such as a patient with diabetic neuropathy. They can't feel their feet. Well, they stepped on a nail and they didn't feel it, which you might think, oh, this is great, I can't feel pain. But because of that, they don't realize that they have developed an infection. That infection spreads to the bone, and it's not noticed until it's so severe that they have to lose the foot or sometimes even their life. So pain warns us that something's wrong. It tells us to slow down. You sprain your ankle, you don't want to walk on it. That gives you time to heal and not damage it further by pushing through your pain. So the science, we experience pain. We start with some kind of painful stimulus, or sciencey word is noxious stimulus, picked up by several different kinds of nerves that travel through the spinal cord into the brain, where we kind of process it, and it results in how we experience pain. And that includes localizing it. Where is the pain? Identifying it. Is this like a burn? Or is this something that's too cold? Is it sharp, dull pain? And then initiates the emotional response, the physiologic response to pain. Like my heart rate speeds up, my blood pressure goes up because I stubbed my toe. Two broad types of pain, somatic, which is like the root word body. It includes like your skin, muscle, bones. It's like your classic injury. I stubbed my toe. I know I stubbed my toe. I know exactly where my pain is. And then visceral pain is kind of more wishy-washy. Pain from an organ such as the heart, the appendix, gallbladder, digestive system, where it can refer to other places in your body, and it's harder for your brain to localize, such as feeling a heart attack in your arm or feeling gallbladder pain in your shoulder. All the pain meds we have work somewhere along this pathway, and we'll go into it a little bit later, but some of them work in the middle, some of them work at the very beginning, and all work in different ways and are just different tools in our toolbox to try to attack the problem of excessive pain. So acute pain, of course, is this new onset pain, usually a reason someone's going to call 911 versus their chronic pain. Although I will say I have seen 911 called for chronic pain, but usually related to some injury or disease that you can see. It's usually appropriate for the underlying condition. I have appendicitis. My stomach should hurt. I should have a fever. And it's usually indicative of some new thing happening that's worth investigating. All this mainly to contrast with chronic pain, which is lasting longer than 3 months, or rather longer than what you would say is a reasonable time for an injury to heal. About 20 to 50% of the population. And these populations, and the reason I mention them is, if someone calls, it's not always realistic to expect to get 100% relief of their pain. And an exacerbation of chronic pain is some part of a presentation of, little under 20% of ED visits. These patients are more likely to have pain in their back, knee, neck. They're more likely to visit the hospital frequently, and they're more likely to require higher doses of pain medications, which is the reason it's important to think about. We don't have a good understanding of chronic pain. It's thought that there's some nerve dysfunction from a previous injury, and their body becomes abnormally sensitized to it. And then they get in this vicious cycle of, my leg hurts, so I don't want to move it. And now that I'm not moving my leg, my nerves are becoming more sensitive. They're leading to more pain. And it's this anxious loop. You have a few examples on the bottom there. Fibromyalgia, 5.4% of the population. Complex regional pain syndromes, these things that I'm seeing more and more of in the ED, but basically, like I said earlier, the implication being that sometimes these people are requiring more pain medication than you would give, a kid who's never had opioids that comes in with a broken ankle. But a element of chronic pain can be these medication overuse headaches, which someone might call about, but this is usually someone with chronic pain who takes ibuprofen every day for it. Less common with ibuprofen and NSAIDs, and more common with they took sumatriptan or an opioid for their headache, and now they're completely dependent on that and using it too much. They now are having a new kind of headache, which is fun. One treatment implication here is opioids aren't recommended for long-term treatment of chronic pain. They were once widely used, and then there was a huge uptick in OD deaths, a quadruple over the time that they became recommended for non-cancer chronic pain. And it actually resulted in poisoning being the most common injury-related death in the U.S., more so than car accidents. For us, the implication more so is, treating enough to get to the ED, but then, even in the ED, we defer that treatment of their long-term chronic pain to the primary care physician. Again, the important thing to remember, which I'll keep repeating to drive it in, is they may require more pain medication en route. Here are just some of the options we have, and I talked some, and it sounds like you guys have more so fentanyl, maybe sometimes morphine, ketamine on the trucks, and then when I get into some targeted therapies later, nitroglycerin and that sort of thing. But over the years, medicine's given us a large amount of pain medications. Acetaminophen is Tylenol, classic, over-the-counter medicine. It's also important to think about its presence when you combine it with things like hydrocodone. Even if you're not doing calculations in the field, like, should I give a hydro to this patient? They've taken this many milligrams of Tylenol, blah, blah. You could still be getting a history from a patient. They have chronic pain. They say they've been taking a lot of Tylenol on top of their hydrocodone max dose, they may not know or remember that they've been told that it's bad to combine those until they're calling the ED with full-on jaundice, liver failure. So that's one important thing to think about. NSAIDs, our non-steroidal anti-inflammatory drugs, include like ibuprofen, naproxen, Mobic, aspirin is the first and classic one. Other common over-the-counter opioids are the big gun and the major point of the presentation. Include things like fentanyl, morphine. Ketamine it's special. We'll touch on later. And then, like I said, targeted pain medications are things like nitroglycerin, or for migraine, triptans, which treat pain at its source, even if they're not primarily a pain medication. Just a brief history. Tylenol was first synthesized in the late 1800s, but it didn't become widely used until the 50s as kind of an alternative to aspirin. Its mechanism of how it works is actually not really well known. We know it also